and have this session kind of in a podcast style. And so just to encourage everyone to perhaps, if they're taking a walk during this time, if they're outdoors, or just to be doing something active, since we're all not able to walk together. So we do have some pre-submitted questions that we will be asking our speakers, but feel free to go ahead and type any questions that come up in the chat box, and our committee members will be monitoring this. And then you can also send a private chat message to any of us listed as hosts, and we will be able to answer any other questions that you have. So my name is Saisri Ravi, and I'm the president of the UTRGV School of Medicine's Walk with the Future Docs chapter, and I'm a second-year medical student. And we are really excited to be joined by our speakers today, Dr. Wilson, who is a OBGYN faculty member, and also Mrs. Ava Wilson as well, who is a breast cancer survivor. And we're also really excited to be joined by our RGV community, students, faculty, and then also the Walk with the Doc community members as well. And in a little bit, I'll ask Dr. Wilson and Mrs. Ava Wilson to kind of introduce themselves and share a little bit about their background. But before we get started, since it is our first walk of the year, I would like for our committee members to introduce themselves. And also, I believe our faculty advisor, Dr. Chang, is here as well. So we can start off maybe with Dr. Chang. Would you like to just say a few words about yourself?
Hi, good morning, everybody. Sure. I'm Chelsea Chang. I'm an internal medicine faculty here at UTRGV School of Medicine, and I was part of the class that started this last year. We were really excited because we were the first medical school in Texas to start the Walk with the Future Doc program. And it was just a really great way to get outside, to, role model some healthy behaviors and meet some members of the community and the students and the faculty. So it's been really fun seeing different people show up. Like Sazri said, it's been challenging. We can't do the things the way we used to do them. So I'm really proud of the students for getting this together today. And I'm really thankful for Dr. Wilson and Mrs. Wilson for sharing their expertise too. So look forward to it. Thank you.
All right, thanks, Dr. Chang. So committee members, you all, whoever wants to go first, can introduce yourselves.
Hi, I'm Kevin Abraham. I'm the vice president of Walk with the Future Doc, and I'm just really excited that we get to do this. I'm not currently walking because I'm monitoring the chat, but I hope that everyone has a great time and enjoys what Dr. Wilson and Ms. Eva Wilson have to say. So thank you.
Hi guys, I'm Anne. I'm secretary for this wonderful club. Thank you so much for joining us here, and I can't wait to start because I'm in Houston right now and it's actually kind of cold, so I'm very excited to walk. See you guys.
Hi everyone, my name is Niti. I'm also an MS2 and I'm the treasurer, and just like everyone else, I'm really looking forward to this session and hope we can start a new trend of having more of these Zoom Walk with the Future Docs, so really excited.
All right, so I'm just gonna kind of do a brief introduction. And so as you all know, since it's Breast Cancer Awareness Month, we thought it would be fitting for this to be our topic for this particular walk. So it is really becoming more and more common to see diagnosis of breast cancer, and many people are affected by it or know loved ones and family members that are affected by it. And perhaps part of this is due to the fact that we are able to do more and more mammograms and early screening. And so the diagnosis of breast cancer, we're able to do this earlier. However, interestingly enough, some research by the Mayo Clinic has suggested that since mammograms have been implemented, the incidence of breast cancer over time hasn't really showed any increases. And so that's just something to keep in mind. one kind of statistic by the CDC that I wanted to share is that more than 230,000 cases of breast cancer are diagnosed in women in the US every year. The big question that really worries everyone is why do women die of breast cancer, and what can we do about it? And to kind of simplify this a little bit, there are really kind of two key aspects of this. One is the biology of cancer itself. It is still a very complex disease, and there's still a lot to be found out about it. And so, there's still not enough information in some areas about our understanding about the disease. And then the second aspect is there is kind of this nature of avoidable deaths as well. And so sometimes due to lack of appropriate medical care, whether that's due to socioeconomic status, cost of therapy and drugs for medical treatment, these are all factors that kind of play into this as well. And so another thing too is that 20, 30 years ago, breast cancer treatment was kind of, the approach was kind of a one-size-fits-all approach. And now that's really not the case because it's very individualized to the type of cancer that a woman has. And so it's really important to look at that biology of the disease to identify any molecular lesions and patterns and measure those in the clinic and target kind of the specific treatments for cancer towards that. So just kind of at a general level, there are a few different types of breast cancer that have been kind of identified based on certain hormones and certain growth factors. So kind of the three categories that breast cancer is often divided into is kind of the estrogen receptor driven positive type, and then the progesterone positive type, and then the HER2 growth factor type. And then there is also another type, which is kind of like the triple negative, where there isn't a presence of any of these hormones or growth receptors. And so for this, there are newer therapies that are coming out trying to kind of target what is actually going on in this triple negative type of cancer as well. And so really the first thing to look at is often what kind of basket a patient is put in. And so, and then going from there based on, in terms of the treatment. And Dr. Wilson can speak to this a little bit more as well. But the key thing in terms of awareness is really to be aware of any changes. And breast self-exams are really important. And not just for women, but also just being aware of how the body changes and for everyone, and to notice kind of these changes and then also seek help when you do notice these changes. And then also kind of being an advocate for yourself and other women as well, through in terms of advocating for getting screenings done and mammography. So that was just kind of a brief overview that I wanted to present. So now I'm going to turn it over to one of our committee members, Niti, who is going to be talking a little bit about breast cancer in the Rio Grande Valley.
Hi, everyone. So I just had a little bit to say. So this summer, I did a little bit of research with Dr. Maheen, and she works with genetic testing. And I read a paper with her regarding just genetic testing with breast cancer in South Texas, especially like our area in the Valley. So just to give a little introduction to that, breast cancer is the most commonly diagnosed cancer and the leading cause of cancer death amongst Hispanic women. And the prevalence of hereditary mutations in BRCA are a lot higher in the Hispanic population, with Hispanic women usually are diagnosed at a much younger age with a more advanced stage. But it's interesting that today the research that's done in BRCA is mainly conducted in non-Hispanic white populations. And there are a few studies that are done on other races and ethnicities. And another thing I found really interesting is that even when you do research studies in the Hispanic population, we don't realize that there's so many different ancestries. Like people from the west side of the United States are predominantly of Mexican origin, where people from the eastern side is a lot of Puerto Rican, Dominican, and Cuban ancestry. So there was a recent study done in El Paso, Texas, where about 41% of the BRCA mutations, they were identified as being recurrent mutations from the Mexican origin. So they identified 12 specific gene mutations that had Mexican descent. So that just leads to the question of, should we kind of approach screening, if we did like a more cost-effective approach of screening based on the country of origin, will that help us? It will kind of prevent patients from having to do like the whole complete sequencing and become more targeted and more focused. So I just wanted to throw that out there and see what Dr. Wilson had to say, perhaps.
Okay, great, thank you. So now we're gonna move on to introducing our speakers, Dr. Wilson and Mrs. Ava Wilson. So if you all would like to introduce yourselves and kind of share a little bit of background, that would be great.
Yeah, sure, thanks. Thanks for inviting me. Okay, I'm Dr. Wayne Wilson. I'm on the faculty of the medical school in the Department of Obstetrics and Gynecology. I'm the assistant clerkship director for the third-year clerkship in obstetrics and gynecology. And Dr. Chang and I are the co-directors of the second-year clinical skills course. So anyway, yeah, so thanks. I've been in private practice here in the McAllen area for 36 years now. I started practicing back in 1984. So yeah, I probably have to give a patient a diagnosis of breast cancer about once a month. I encourage my patients to start having annual mammograms at age 40. There's a recent study in England that suggests that the mortality rate will drop if you start screening people at the age of 40 as opposed to 50 and older. The most common cause of death of all reasons in women between the ages of 40 and 50 is breast cancer. 50 and older, it's cardiovascular disease. Breast cancer is the second most common cause of death. Prevention, it's basically prevention has to do with lifestyle. Those women who average drinking more than one or more alcoholic beverages a day have a higher risk. Women who smoke have a higher risk. Obese women have a higher risk. Women of African heritage have a higher risk, and that has to do both with genetics and with socioeconomic issues. Otherwise, family history plays a role, but that's not really modifiable. You were talking about BRCA1, BRCA2 mutations. Those actually account for only about 5 to 10% of all cases of breast cancer. You have to have kind of an index of suspicion to recommend the screening. The screening's been available for about 20 years now. For a long time, there was only one laboratory in the United States that actually did the genetic screening for that. There's now more laboratories available to get it done. Originally, it was a very expensive test. It was about a $4,000 test, and for that reason, people, especially if you had no insurance, it was very difficult to be able to afford to have the testing done. So I have now, I guess, about 10 families that have tested BRCA positive, either one or two. My wife can speak to a friend of ours who was a coworker of hers that was BRCA positive that actually died of her breast cancer at a young age. Treatment, well, again, let's go back to diagnosis. Diagnosis basically has to do with getting mammograms. Like I said, I'm a strong believer in mammograms. If my wife hadn't had a mammogram when she did, she probably wouldn't be here today. So I'm a very strong believer in regular mammograms. Some women are afraid to get mammograms, saying that they're No, talking about the X-ray radiation exposure. But with low dose mammography, it's extremely low, and it does not increase the risk of breast cancer by having multiple mammograms. There was a question about when to stop having them, and that's an interesting question. Recommendations are to stop doing any sort of cancer screenings like mammography or colonoscopies or whatever when there's less than a 5-year expectation for the rest of your life, which is sometimes kind of hard to predict. So I would encourage. Normally, what I do is I encourage women 70 and older. They can probably start having their mammograms on an every 2-year basis instead of an every year basis. By far, the diagnosis of breast cancer is made most commonly in women between the ages of 50 and 70. So again, I think that an annual mammogram between those ages is very important. The mortality rate from breast cancer is actually dropping in the 50 to 70 age range due to making the diagnosis at an early stage. The cancer is much more survivable at an early age, if it's diagnosed at an early stage. And so the incidence in mortality of breast cancer has dropped almost 2% over the last 10 years due to early detection. So it's very, very rare for me anymore to find a woman with an advanced breast cancer. If she has an advanced breast cancer, if it's already reached the lump stage, most of the time that's kind of a product of denial or neglect. The person hasn't either wanted to go get a mammogram or has just ignored the lump in their breast. So anyway, again, a lot of breast cancers now are diagnosed at a stage 1 where the breast cancer is just isolated to the breast or to the breast plus a sentinel node. So most of the time, those cancers are treated just with lumpectomy and then chemotherapy and local radiation to the area where the breast cancer was. Fortunately, some breast cancers are diagnosed as a ductal carcinoma in situ. Those are normally treated just with local excision and X-ray radiation and don't need any sort of chemotherapy. Stage 2 and higher, surgery is indicated plus chemotherapy and radiation. And metastatic breast cancer, for the most part, is just treated with chemotherapy. The surgery is not helpful in women that have, for the most part, women that have metastatic breast cancer. With that, I guess I'm gonna we'll have questions and answers later, but I'm gonna just let my wife kind of explain her story now.
Hi guys. My name is Eva, and I am 15 years out from having been diagnosed with DCIS, ductal cell carcinoma in situ. I was 35. It was my first mammogram, and my cancer didn't present itself. I didn't have a lump. I had no pain. I was active, physically fit, no family history. So I don't know. I was just a wild card. I mean, I don't know what the incidence of that is, but what saved me was that mammogram, and I had it done at 35. So it was unilateral, so left side only. Removed all breast tissue, all skin, and the first chain of lymph nodes, and my margins were clean. Let's see, what else?
Reconstruction.
Oh yes, I had reconstruction with skin expander because all the skin was removed. So I had a bilateral reconstruction. gosh, there was something else.
Physical therapy.
Oh, and I was fortunate enough to be working in an outpatient rehab facility as a speech therapist with physical therapists and occupational therapists. And what's very interesting to me is that no one ever suggested, my surgeon didn't, my reconstructive surgeon didn't, nobody recommended, my husband didn't. I mean, it's just not a thing that people knew about. Nobody suggested any type of rehabilitative therapy. And my good friend, who's a physical therapist, noticed that I was having problems with my posture and pain. I had recurrent pain, and I was developing scar tissue. And so I was able to go through physical therapy for several weeks, several times during the next couple of years, which gave me my mobility back. I was even starting to have some bony changes because of my guarding posture, and I had chronic pain. So through myofascial release and I guess massage and range of motion exercises, I was able to regain pretty much all my strength and range of motion. But that's something that I think is neglected with patients. It's the mechanics of it. It's fixed, you know, cancer removed, whatever, and that's it. So I highly recommend that therapy, depending on the patient. I guess because I had skin removal, I had really limited range, so I was tighter on that side. But I guess it would depend on the patient and how they present physically after surgery. So, anything else?
Well, if you want to do it. She had Eva had a coworker that's actually a patient of mine. And her mom and her sister had both had breast cancer. The mom that was tested?
Mom had it, sister had it. They were both BRCA positive.
Both BRCA positive.
And my friend, during her second pregnancy, she never had a mammogram. She was 33 at this point, found a lump. And at that point, she had treatment for a year.
Well, I was her obstetrician. She actually went to MD Anderson and had chemotherapy during the pregnancy. Interestingly, chemotherapeutic agents, even adriamycin and the taxanes and the platinum-based chemotherapies can actually be given to pregnant women during the second and third trimesters of the pregnancy. So anyway, she had neoadjunctive chemotherapy while she was pregnant. That did shrink the tumor down. I delivered her at about 38 weeks. And then she went back to MD Anderson and had her mastectomy done. But unfortunately, she passed away about 18 months after her baby was born. So.
And I was BRCA negative. I was tested, and so no family history.
So yeah. So again, only 5% of breast cancers happen prior to the age of 50. But a lot of those women will be there'll be a higher percentage of those women that test positive for either the BRCA1 or BRCA2 mutations. And unfortunately, women that are diagnosed with breast cancer at a younger age, the cancers tend to be a little bit more aggressive, and the mortality rate's higher. So I guess, by the way, just so you know, I've already been walking this morning. I actually went out and
you're feeling guilty.
Yeah, everybody's walking there. But I actually I went out fishing this morning, so I already caught 2 fish, and so we got lunch. So anyway, I guess at this point I'm gonna send it back to you, Saisri, and we can go from there.
Sure. So I think at this point we can open it up for questions. We do have some pre-submitted questions, but I just see a question here in the chat that we can maybe go ahead and start with, which is there an age at which mammograms should be stopped?
Yeah, well, I think I addressed that earlier. I mean, you know, basically, when your life expectancy is 5 years or less, you can stop all cancer screens. But again, Dr. Chang maybe can address, you know, how do you determine when somebody has 5 years or less to live? So, you know, again, it's somewhat subjective. I normally suggest, you know, if a woman is healthy, regardless of her age, like I said, over 70, I suggest that every 2 years is probably adequate as opposed to every year. But I don't know. What do you say, Dr. Chang?
It is a challenge. I think it's something that's great to discuss with each individual patient. Like you're saying, at 70 or even at 75, for me, the light bulb goes off that we at least need to discuss if this is something we should consider continuing doing or discontinuing, and seeing the patient's preference on that. If they have other major comorbidities like stroke, heart attack, other malignancies, kidney, liver disease, then it might be reasonable to take a break or stop it entirely. And I get totally, sorry, I'm out here scootering. Benjamin, you say hi? Hi. I get totally different responses. Some patients say, oh my gosh, I can stop, what a relief. And then, so that's amazing. Hi, I'm Raymond. Goodbye. I don't want it. Goodbye. And then some people are very, have gotten to use that mammogram as, you know, it provides them a lot of relief and security getting that normal mammogram result, and then they're very hesitant to discontinue that, and so I take that into consideration and continue that with those patients. So I think it's an important shared decision making.
Yeah, thanks. Just as an aside, we normally stop doing PAPs on women at 65. But again, basically the risk of cervical cancer is pretty well zero at that point, as long as they haven't had any dysplasia or any abnormal PAPs for the last 20 years. But same thing as far as colon cancer screening goes. Again, you know, like Dr. Chang said, I think all of these things are just kind of, you know, between the doctor and the patient as far as when you stop doing those things.
Sorry, if there's one other question, I was wondering if y'all wanted to comment on what about or Mrs. Wilson or Dr. Wilson, one of the things that's difficult to measure is the anxiety that comes along with frequent testing or false positives, you know, that mammogram that comes back with a concern for something and ultimately is negative. And so I didn't know if either of y'all wanted to comment like on the anxiety perspective of it, especially being diagnosed so young, Mrs. Wilson, and then having to have, you know, all those follow-ups and carry that, you know, the rest of time, how that's affected y'all or how y'all manage that.
Well, I did have a mammogram that was concerning maybe 2 years later. And had a biopsy done, and it was nothing. It was just, and it was on my opposite breast, on my healthy breast. So that was that caused a little bit of anxiety, but I'd rather know and get it checked than not, you know. So the anxiety of not knowing to me was worse than, you know, come check this out, something's up. Oh, good. Okay, yes, let me get in and get it checked out. So,
yeah, Dr. Chang, you're right as far as that question has been addressed. You may have read some articles about that as well, about the pluses and the minuses as far as the more frequent mammograms versus the anxiety they produce. Normally, when a woman has her first mammogram, it's not unusual at all for the radiologist to ask for additional studies. So when I give my patients an order for their first mammogram, I just warn them in advance. Say, look, it's very, very likely that you're going to have to come back for an ultrasound or a spot compression or something like that, or even maybe an MRI, because it's your first exam and you don't have any previous exams to compare that with. So yeah, I mean, I normally will have 2 or 3 phone calls a week, just reassuring patients that no, this is okay. It doesn't mean there's anything wrong. They're just wanting you to go back so that they can make sure that there's nothing going on out of the ordinary. So overall, my feeling is that most of my patients are reassured, don't mind going, having frequent mammograms or actually having to go back and get additional studies, because ultimately the majority of them are reassured that they don't have anything going on. And again, I have discussions with patients that they do make the diagnosis of breast cancer, and I tell them, if you do have the diagnosis of breast cancer, it's going to be caught at a very early age and is very treatable and survivable. So again, if you do have a breast cancer, the mammogram has done its job. It's found the breast cancer, and it'll be attended to at a very early stage.
Thank you.
Okay, so I think we can go ahead to some of the pre-submitted questions that we had. Anne, do you want to go ahead and look at our list and ask the first one?
Your mutes.
Sorry. One of the questions from a community member is, when should women start screening for breast cancer? Can men get breast cancer? And is breast cancer the most common cancer? And in parentheses, it says it seems to be the most promoted, but maybe that's just all the pink.
Yeah. Well, breast cancer is the most common type of breast cancer. I'm sorry, most common. Well, actually, skin cancer is the most common type of cancer in women, but it's very survivable under most circumstances. Breast cancer is actually the second most common type of cancer in women. More women die from lung cancer than die from breast cancer. So don't smoke. But that said, again, we're not really talking so much about prevention as we are early detection with mammography. But again, I'm just a very strong believer in getting annual mammograms. For my patients, I'm recommending after the age of 40.
Okay, great. So another question that we had from one of our students is, for women with dense breast tissue, what type of supplemental screening is generally recommended?
Prior to the menopause, most women do have dense breast tissue, and Dr. Chang's husband's a radiologist. He reads some of my mammograms, and there's always a disclaimer about the sensitivity of the interpretation of the mammogram is going to be decreased with dense breast tissue. So as it turns out, there's really no adjunctive imaging that really helps with dense breast tissue. You just have the radiologist just has to do the best that they can to interpret the mammogram with the dense breast. That said, again, I normally don't order mammograms in younger women, say prior to the age of 35. If they have a lump, the first imaging study that I'll order will be a sonogram, because the lump will either be a cystic lump or a solid lump. Most of the time, if it's a solid lump, it needs to be biopsied. But the vast majority of those are not going to be breast cancers. They're going to be fibroadenomas, which is a benign tumor of the breast. So dense breast tissue does make the interpretation more difficult and challenging for the radiologist. But again, the only adjunctive imaging studies that are available are either sonography, spot compression studies, or MRIs.
Well, that actually leads us to our next question. When are MRIs used as breast cancer screening? And there was another question that asked about what factors indicate the need for an MRI following an ultrasound.
Mammography is still the the primary screening technique for breast cancer. MRIs are ordered sometimes in women that have been identified as being a higher risk for having breast cancer than just the baseline population. The thing about it is, you know, most of the time a woman can get a mammogram for $120 or less. They're cheaper in October for Breast Cancer Awareness Month most of the time, whereas an MRI may cost $2,000 or $3,000. And so the cost of the study comes into play. Women who have had breast cancers before are more likely going to it's going to be more recommended for them to get an MRI.
I had an MRI every year for 8 years, with and without contrast dye, after my breast cancer, and then was told really after 5 years that's sufficient. So finally got to stop that.
Yeah. The thing about MRIs is the sensitivity is somewhat lower, but the specificity is higher. So you're going to find more breast cancers with an MRI than you would with a mammogram, but you're also going to find a whole lot of other things that aren't breast cancers that are going to require biopsy. So you end up doing more breast biopsies with MRIs, but you also do find more cancers as well.
Okay, so kind of to shift gears a little bit regarding COVID. So how has kind of like the COVID protocols and the caution towards non-elective surgeries and screenings, how has that affected breast cancer cases, both in terms of, you know, screening and diagnosis and then also management?
Well, back in the spring, most of the imaging centers shut down because of COVID. Pretty much most of them are up and running right now, but I did read an article in JAMA over the last 4 weeks or so, suggesting that some breast cancers that would have been diagnosed earlier went undiagnosed because of the delay in getting the mammogram done. So at this point, I actually did have one patient who had a breast cancer diagnosed back in, I think, April. And actually her surgery was postponed for like 2 months because of COVID. At the end of the day, I don't think it had any impact on her stage or her long-term survivability of the breast cancer, but it was her surgery was postponed by 2 months. I think at this point in time, I mean, I'm doing elective surgeries now. I'm not just doing urgent or emergent surgeries. So pretty much at this point, I think all the mammography, the imaging centers that I send my patients to are all up and running, and the general surgeons that I refer my patients to for their surgery are all they're all able to do their surgeries in a fairly timely manner.
So there's a question in the chat from Vania, and she asks, how do you approach relaying the news of a breast cancer diagnosis to a patient? So I guess both Dr. Wilson and Mrs. Wilson, if y'all would answer this, it would be great.
Yeah, well, again, you just have to be as straightforward and as calm as you possibly can. You just tell them this is what it is. Most of the time, you reassure them that it's again, if it's caught at a very early stage, it's very treatable and very survivable. But you know, no one likes hearing bad news, so you just do the best that you can as far as reassuring them that they're going to be okay.
Yeah. Well, my OB-GYN is my gynecologist is Wayne's partner, and it was incredible how quickly the results were in. I had my first ever mammogram on a Thursday, and results were in on a Friday. So when I was given the information, I mean, I just handled it very matter-of-factly. Okay, what's the next step? Biopsy. Okay, meet with the surgeon, okay, meet with the plastic surgeon, when surgery. Looking back, I was in shock. I was like, okay, let's go, let's get it done. But yeah, I mean, so much of it depends on the individual, I guess, personality of the patient too. I mean, you're gonna have people that panic. You're gonna have people that don't. Yeah, I mean, I don't know what else to say about that. But yeah, always, I would say it's always nice to have hope. So no matter the situation, you've got to give hope. You know, you can't make any promises, but you can be as positive in that situation as possible, because that will go a long way.
Yeah, Vinay did a sub-internship with me back in August, and I'm sure you remember. That's the one thing that I always tell my students. I've normally got third or fourth year students with me most of the time. That you always no situation is hopeless, and it's very important to always impart that the hope is there, and that there's every expectation that this is going to turn out just fine.
Okay, so we have another question in the chat from Brian, who asks, can you talk more about the lifestyle factors that you mentioned earlier? Does physical activity and good nutrition help prevent breast cancer, or anything else that helps?
Yes, excellent question, Brian. And all of those things are important. All those lifestyle issues, staying physically active, eating there's a suggestion a Mediterranean diet it helps to lower your risk for breast cancer. Again, not being obese, because obesity in and of itself is a risk factor.
Stress levels stress is huge. Emotional stress. I had been through, I was extremely physically fit. I'd been a runner all my life. I ate well. I wasn't overweight. I breastfed. But I had gone through about a 10-year period of tremendous stress. And in my gut, I feel that that's what did it for me. So,
just other issues is, because we talk about this during the third year OB-GYN clerkship rotation, exposure to estrogen and progesterone over the course of your life. So other risk factors are early menarche. The younger a woman starts having periods and the older she stops, is an increased risk. So basically the number of menstrual periods that a woman has in her life is a risk factor. So women that have fewer menstrual periods, say that start their periods at 14, 15 and end in the early 40s, are going to have a lower risk for breast cancer than those that start their periods at 10 and end at 54. Breastfeeding actually decreases a woman's risk for getting breast cancer. So again, I think that a lot of that has to do with the fact that most breastfeeding women won't have a menstrual period over the course of time that they nurse. But just by in and of itself, that lowers the risk. Exposure to birth control pills or postmenopausal hormone replacement therapy can increase a woman's risk for getting breast cancer. Kind of the cutoff there is 3 to 5 years if they're exposed. If they're on birth control pills for less than 3 to 5 years, their risk is probably the same as the woman who's not taking birth control pills at all. And that the same goes for the postmenopausal woman who's on hormone replacement therapy. If she limits her therapy to 5 years or less, more than likely her risk factor is not going to be that much greater. But again, lifestyle issues, very important. Diet, very important. Limiting alcohol intake, don't smoke. All of those things are important. So that was a good question. That was a good question, Brian.
So, how common is breast cancer in men, and what is the prognosis usually like when there is a positive diagnosis?
Yeah, excellent question. About 1% of all breast cancers happen in men. So again, I think the numbers I saw were like there's going to be, I think they're estimating in 2020 about 275,000 cases of breast cancer diagnosed, and about 1% of those are about 2,600 cases of breast cancer are going to be in men. The incidence of breast cancer in men is pretty much probably what I have read is over 50% of cases of breast cancer in men, they're going to carry one of the BRCA mutations. So again, like I said, I've got about 10 families now where I've made a diagnosis of either a BRCA1 or a BRCA2 mutation. And so I've had to actually do some genetic counseling with some of the males in those families as far as, there's a recommendation for men to get mammograms if they are BRCA1 or 2 positive, and just to do, breast self exams, encourage breast self exams.
Okay, another question we have for both of you is, what are your thoughts on genetic testing? What age do you think this should be done? And would you recommend it to, patients or, family members? What are your thoughts on this?
Well, again, if somebody is tested positive for one of the BRCA mutations, then it's normally not recommended to test children prior to the age of about 18 or 20, something like that, because it really doesn't have much of an impact on their lives until they reach a point where they might be susceptible to getting breast cancer. As a rule of thumb, we recommend starting to screen. If there is a family history of breast cancer, like Eva's was diagnosed at the age of 35, so our daughter should probably start getting mammograms at the age of 25. Normally, the recommendation is to start screening 10 years prior to the age of onset of the first-degree relative who got the cancer. So again, as far as if somebody screens positive for one of the BRCA mutations, pretty much all of the first-degree relatives around that index patient should be tested for BRCA. That would include, say, hypothetically, if she had tested positive, she's got 6 siblings, they would all should be tested. And part of the reason for that is it's important for the person to know whether they carry the mutation or not, but it's also important if they carry it that they have their offspring tested at an appropriate age because it's an autosomal, it's transmitted autosomal dominant. So I mean, the offspring are going to have a 50% chance of having it as well.
That's an interesting question, because I'm thinking, I was so anxious to get BRCA tested, and I was so relieved when it was negative, and thinking about my daughter. But looking back, if I had tested positive, I think I'd be stressed for all the years until she could have her first mammogram. So negative gave me peace of mind, but if I was positive, that'd be stressful, I think. But I was negative, so neither here nor there.
Yeah, and again, the other issue about BRCA screening is also, I mean, men or women that are BRCA positive, women have a higher incidence of ovarian cancer, and also men have a higher incidence of prostate cancer, and both sexes have a higher incidence of pancreatic cancer. So again, for women that are BRCA positive, the majority of those women at some point in time elect to have bilateral mastectomies and bilateral oophorectomies to eliminate the risk of getting breast or ovarian cancer.
And just because you're BRCA positive doesn't mean that you will develop cancer. In fact, we've got some close family friends who recently, there's 2 sisters and a brother. So one of the sisters, the younger sister, ended up with a lump. She tested positive for BRCA. So
And she had breast cancer.
And she had breast cancer. So had her mastectomy, went through chemo, So now the mother and father were going to get tested for BRCA. And it ended up being that the mother, who's 65, 66, she's positive. So the gene came from mom. She's never had cancer. And she doesn't have cancer now. So that's interesting. So the gene came from mom. Mom's 65, 66, and she hasn't developed it. I don't know that she ever will, but now the other sister, the sibling, she tested positive. So she's going to have the preventative surgeries of bilateral mastectomy and oophorectomy. But it's interesting, the gene came from mom and mom's never had it.
So yeah, I mean, the overall incidence of cancer in the general breast cancer in the general population is about 12%, or about 1 in 8. But if you have a BRCA1 or a BRCA2 mutation, your chances of getting cancer or breast cancer are around 70% instead of 12%. So again, yeah, 30% of women that carry the gene, men or women, won't ever get breast cancer, but 70% will.
Yeah, I think just to, sorry, I saw you were about to speak there, but I think the big misconception is I have a lot of patients that say, well, I don't have any family history, so I'm going to pass on the mammogram, thanks. But that's not the right choice. You know, like it's been emphasized that the majority of breast cancer diagnoses happen in people with no family history. So getting that message out to, you know, our family and friends and community, I think is really important. So people know that they're at risk even without a family history, since that's the most common scenario.
Mm-hmm.
And then just to emphasize on, oh, sorry, go ahead, Dr. Wilson.
No, I'm sorry, I didn't mean to interrupt, but yeah, I mean, that's a very, very good point, because only about 10 to 15% of women that get breast cancer have a positive family history. I guess Inez had a question earlier about family history. And again, you know, as far as screening goes, you know, if say someone has a mom who was diagnosed with breast cancer at the age of 45, then the daughters should start screening 10 years prior to that, which would be at the age of 35. But again, yeah, family history does play a role, but it's not a huge role. And again, I've run into the same circumstances that Dr. Chang has, as far as, you know, a woman not wanting to get a mammogram just because there's no family history. But I'll present that statistic to them, you know, that, you know, only 10 to 15% of women that get breast cancer do have a first-degree relative who's had breast cancer. So that's not really a legitimate argument for not getting a mammogram.
So I think we only have time for one more question. So to Ms. Wilson, what was your support group like? How can one without a support group cope or find resources?
Well, I was blessed to have very great support. You know, I have a big family, and where I was working, the rehab facility I was working at, you know, they're all therapists. They were all fantastic, supportive. Of course, Wayne and friends. I never attended any support groups or, you know, anything like that. So I was blessed to just have a personal community that supported me and helped me.
Okay, great. So I think we're at the hour almost. And so if there are no other questions, I think we can go ahead and close out the session. Thank you so much, both Dr. Wilson and Mrs. Wilson, for joining us today. I know that I think everyone really learned a lot and gained a lot of insight. And so we're really happy that you guys were able to join us. And thank you to everyone who joined us as well from both the RGB community and then the Walk with the Doc community as well. This was kind of our first virtual event, and so we're hoping to kind of continue this throughout the year with these virtual series. Does anyone else have any other thoughts before we close out?
Just thanks for inviting us.
Yes,
this was great. Really.
This was very therapeutic.
Okay, yeah, thank you so much again. And we look forward to hosting the next session and hope to see you all there as well. Okay, thank you.
Thank you so much.